Guys, grab your seats. Why don't you get some of the guys who are at lunch to hurry up a bit, perhaps? So the rules are, I think you guys know the rules. Gentlemen, let's have some order there, please. No talking among yourselves. Yeah, so it's a huge group, and we might, we've got a lot of interesting cases. So please don't repeat what the previous guy said. Yeah. If you have something additional, then by all means, bring it out. So that way we'll try and get as many cases as possible. All these cases need surgery. So there is no conservative treatment here. You just tell us what you're going to do and why. All right? So let's start. Parag, you got the first case lined up.
Yes. So this is a 60-year-old lady. She came with the complaints of pain in her left knee and deformity. She had an HTO which was done about 14 years ago, and now she complained of pain, slight limp and difficulty in walking. So these are her X-rays, which you can see, the AP lateral and the long leg X-rays. And the question here is, what is the plan further? What do you want to do for this patient who has pain, limp, deformity and difficulty in walking? So can we start with Dr. Ashok Rajgopal?
So Parag, there are three issues that I see here. One is this patient has a extra-articular deformity in the proximal tibia. She's got hyperextension. The patella is low-lying. So these are the three things that you need to consider. The incision obviously would be a factor. You need to factor in what the incision is. Technically, the challenges that I see is, again, going back to addressing the issue of the incision. If it is transverse, I would go at right angles. If it's a lateral incision, and I could use it. So whichever the practical incision is to do that. I would use the principle of addressing the tibial resection pretty much along the lines that have been made, except that I would cut at right angles to the long axis of the tibia, which means that we would need to do a pretty extensive medial release. The femur should be relatively straightforward. I would distalize my femur to compensate for the hyperextension. My bias in terms of implant choice, I would use a stem in this case to get my alignment on the tibia just right. I would distalize the femur. Possibly...
Okay, so I think, yeah, we've got the gist. So you would think of whether you want to do an all-intra-articular correction or an extra-articular correction.
All intra.
All intra. So Rajesh, do you think there's a possibility that we could think of doing a two-stage or a single stage procedure where we do extra-articular osteotomy?
I don't see the need. I don't see the need.
So anybody in the panel feels that we should do an osteotomy to correct this deformity, and or is everybody willing for one stage?
One stage.
Okay.
Just one point. How do you guys determine the problems with the offset of the tibia and the rotation? So if there's a rotational malalignment, how would you determine how you're going to position your tibial component? Because when the osteotomy is done, sometimes you've got a rotational malunion. Anyone?
Use a stem. Use a stem. An offset stem would do very well over there, and align the tibial rotation in sync with your offset stem.
Go back to
and that should take care of it. In terms of the rotation, you just follow the same guidelines.
Would everyone agree that you need an offset stem in this? If you lateralize it, would you need an offset stem?
No, and I think if you're going to use stem and metaphyseal fixation, then you can just put a straight stem down there. And I personally would use a mobile bearing revision system as a primary. So we haven't got to worry about rotation of the proximal component, and we can just bypass the defect.
Anyone worried about the reverse slope of the tibia?
Absolutely.
It's sloping anteriorly, you know.
Yeah.
That can mislead you when you're doing your tibial cut. So you really need to take off very little on the tibia. Would you agree?
And I think
the line that he's marked there may be excessive.
That's right, and I think this is where the tibial osteotomy sometimes leads you astray, because if I think the tibial osteotomy was done some years ago, is that right?
Yeah.
Yeah. So
14 years ago.
Right. So usually they're not done very well, unless it was done by you, Parag, in which case it was done marvelously. But oftentimes, as Aaron was pointing out, after a tibial osteotomy, you have a reverse slope, and they also get the rotation. They alter the rotation, so it's very difficult to judge the rotation. Not a problem if you use a mobile bearing, but I use a fixed bearing, and so I would actually align the tibial rotation using the patella tracking.
Yeah.
So if the patella tracks well, I'll let the tibia float until it finds its position, and then I'll pin it in that place, so that that's my tibial rotation.
Anyone might think of using a mobile bearing, just so that you can have that much more play. You know, you're not that worried about malpositioning your tibial tray with a fixed bearing.
Yeah, I said I would certainly use this as a mobile bearing revision system as a primary. So I can bypass the defect, I can not worry about the rotation, I can cut the tibia as I need to for the implant.
And can I
think the problem with the mobile bearing is the potential for flexion laxity and spin out in this case. So I would not use a mobile bearing. I'd use a PS knee with a wide medial release. It looks like that's been a Mackay procedure rather than a closing wedge. Is that correct?
That's right.
So it's probably rotationally not that different. I'd navigate it, and I think you could do it with a primary implant with a stem extension with screws and cement.
Yeah. So how many of you said you'll use a PS implant? So how many of you would use a PS implant in this? The remaining, I assume, will use CR. So how many for CR? So any issues?
And what about the others? You're probably going to do a uni, Chris, because you said you didn't put up your hand for a PS or a CR. So
I'd be worried about, first of all, the recurvatum here. I mean, we don't have very much experience of recurvatum, but the ones that we have tend to have, neuromuscular problems. So we go to a rotating hinge at the drop of a hat. So I would have that ready for this kind of case, because, I'd be worried about the type of release media you might have to do in order to correct that deformity, and also the recurvatum.
Okay, so I think since we have some paucity of time, we should...
Let's move on.
We plan to do 8 minutes one case, so we are already over time. So what we did was an all intra-articular procedure, which all of you said. We did an reduction osteotomy, which is very nicely described by Arun. You undersize the tibia and slightly lateralize it. That's what we chose, and this is the intra-op picture, and this is the post-op X-ray. As you can see, we put a screw as was suggested. There was a bone defect. This was the osteotomy lateralized, and this is the 1-year alignment X-ray, and the patient did pretty well. So the patient is now 6 years down the line, and she's extremely happy at this point of time.
One last point about during the exposure, very often the patella tendon is tethered down to the proximal tibia, and you've got to take a great deal of care while doing your exposure, especially getting the patella out of the way. You might just want to subluxate it rather than evert it during the exposure.
I just have a question to you. I mean, did you use navigation or?
No, this was without navigation.
Right. I think also PSI is a very good option for these cases.
Yeah.
You can get the offset, the rotation, and the slope, and everything is easier.
Okay.
And that's the last question we'll take from you guys, okay? We are going to be asking the questions.
Okay, so the next case, Arun.
So this is a guy with a bilateral problem. You're just looking at the left knee now. Suggestions. The fractures have both united or malunited. So there's a little bit of extra-articular deformity on both the femur and the tibia. Guys, anything particular?
Yeah, so David, do you want to go for this one?
A, do you want to get that femur out, or you're going to navigate and therefore not use a...
Michael?
I would do a navigated knee with intra-articular correction with bone cuts. Could you tell me what that deformity is in angles? Is it about 10?
About
12?
15.
15. I think it's right on that. I think it's possible to do it just by getting a neutral mechanical axis with bone cuts in that case,
So
and
only
not remove the implant and do it navigated.
Anyone different? Anything different, anyone?
I would discuss a uni with them.
Options?
No, this is a young guy, 55 or so. No, 55-ish, this one. Uni.
So let me ask all of you, how many of you use navigation routinely in your practice? Hands up. So for all the cases, how many of you are selective users, like you would do the odd one? So it's either yes or no, that's...
You either use it or you don't.
Yeah, fine. So...
Okay, this was just a quickie, just to follow on with Parag's case, and the idea was to illustrate the reduction osteotomy and its value in being able to achieve intra-articular correction, and it's pretty stable, so we've used a mobile bearing here, just to show that even in the presence of an implant, you can use a miss the nail technique when you're navigating, and then that rod doesn't really pose any problem. If you don't use navigation, how would any
You can actually use an intramedullary stem as well, because that nail is pretty lateral. It's a very capacious canal. You can use a short stem intra-articular resection guide and go in quite easily.
Yeah, it's on the AP it's lateral, but on the lateral X-ray, your rod would probably go and
It'll just slide along it.
Okay. Yeah. All right. So that was just a quick one, and then this is the reference correction of varus deformity with the reduction osteotomy, and we showed that if you remove 2 millimeters of bone, you get about 1 degree of correction. Just a rough rule of thumb. Okay.
I'll just make one comment if you permit.
Sure.
And if there's difficulty in passing the navigation pins because the rod is too thick, something we routinely do the ortho align now, so that all that you need to do is to pass a pin at the intercondylar area, and you can reference from there. So our handheld accelerometer based navigation can be another choice in a case like this if you do. We have no problem in passing pins. We do the console based in these, but that's another option.
And the other option is, of course, PSI. This might be one of the rare occasions where if you don't want to navigate, PSI might be, and we have the pioneer of PSI sitting right here. So you're happy that we brought it up.
Definitely, with a PSI, it's very good really for extra-articular deformity, the same as, you know, was navigation. But the advantage here was a preoperative planning, especially if you're planning to use a long stem. You can even measure the stem length, diameter, and see if it needs an offset or not with a PSI.
Okay.
Something that you cannot do with navigation.
Yeah, thank you, Mohammed. So let's go on to the next interesting case.
Okay, so after dealing with the conversion of an HTO, now we're talking about bilateral failed unis. Of course, Oxfords don't fail, so this is some other design. Chris, you won't have much of an experience because you haven't dealt with failed Oxfords, but let's see, what would you do here? Bilateral in a 55-year-old lady, 3 years following surgery, no infection.
Well, I mean, obviously the right side is worse than the left. The right side is more difficult than the left, but this shows you what can happen with unis. You know, if you look at the right-hand picture, that tibia has collapsed a little bit, but I bet you it was put in significant varus, and that's caused problems. The ACL may not have been intact at the time of the surgery, because it's certainly not intact now. You can see the translocation with significant damage to the lateral femoral condyle. So the problems, again, with revision, if we just talk about the right side, are all on the tibia. The femur will be straightforward, apart from rotation. So on the femur, you'll get by either with a CR or probably I would use a PS because you're going to have trouble on the tibia. The incision is relatively straightforward. You've got to make it larger. You would certainly need a stem on this. And nowadays, we have a very low incidence of using metaphyseal cones or sleeves, because what can happen is the whole of the medial buttress will be gone. It may well be dead underneath that. There'll be nothing medially. I wouldn't just use a stem and an augment. What I would use would be a metaphyseal. I quite like the cones. I have no experience of the sleeves, but they're probably quite well. So relatively easy on the femur, difficult on the tibia, stem, and a sleeve.
So just a quick question, converting HTO to a TKR versus a uni, in your experience, Chris, which is technically more difficult?
Oh, it depends. I mean, if you've got a dislocated bearing, which does occur, then, and you can't entrap it, then a conversion is really straightforward. If you've got lateral progression following a uni, a medial uni, it's very straightforward. If you look at your HTO, the HTOs can be an absolute nightmare if they've not been done very well, or they can be relatively straightforward. So it depends on what you're dealing with. They can be the most difficult revisions following unis, every bit as bad as the worst revised primary total knee, or they can be really, really straightforward.
Okay.
On the femoral side, you said it's pretty straightforward, but it can be a little technically difficult because once you've got your femoral component out, you have nothing on the posterior femoral condyle.
Yeah, so rotation is...
So rotation is the only concern on the femoral side, to make sure that you don't inadvertently malrotate your femoral component because there's nothing there on the medial condyle posteriorly. Okay. Any other variations in terms of solutions here?
The navigation could help you seat your component and rotation.
Yeah.
Okay, great. So we actually navigated and we didn't have sleeves available at that time. So we've done both using a stem and an augment. And as Chris rightly said, there's a lot of stuff there on the medial side. You've got to curette it out. It's often very soft and mushy bone. So you've got to go to a nice firm sclerotic surface, drill multiple holes in it, and make sure and then we've cemented all this down.
What about the posteromedial defect on the femur, Arun? Was there any bone loss posteromedially on the femoral condyle? In other words, that's a primary implant.
Yes.
So looked like there might have been, but obviously
not significant.
No. Okay.
I see, Arun, that you have taken a very conservative cut on the tibia, which is actually the right thing to do because that was severely subluxated laterally.
Yeah.
And, getting tempted to take more bone off would have led to a very thick poly.
I think the general principle is the bigger the deformity, the less your resections. Because otherwise, and usually they have a stretched out lateral collateral ligament. So if you've taken off already 9 and 9 and you've got about 9 millimeters of stretching, you will run out of an insert thickness. So be conservative, you can always take off more later. Right, Parag.
Yeah, so we go to the next case. Many of us see this quite often. This is a severe varus deformity.
And you can't come to India without having to see these, okay? This is why we call you over here to show you these.
So these kind of cases we see quite routinely. So a severe varus deformity. These are her x-rays. You can see also on the left side she has a stress fracture here, plus severe deformity, not correctable. So what other options here? So let me first ask you.
Start with Ridian. Ridian's sitting very quiet out there.
So would you consider a bilateral or a unilateral in this case? So this is a severely bilateral affection. So what's your take on whether you want to do one side at a time or both sides?
So I have no problem doing bilateral knee replacements, but these are complex bilateral knee replacements. Certainly in my hands, this would not be straightforward. With a couple of issues here. One is reconstruction of the tibial defects, and then secondly, balancing. And for me, the reconstruction is pretty straightforward. We have stems, augments, sleeves, cones. We can reconstruct anything. It's the soft tissue balance that's going to be the issue here.
And what kind of prosthesis do you have in mind?
So my go-to would be a metaphyseal sleeve and stem, bypass that defect, build it up.
Yeah. So Rajiv, you want to say, so would you do a bilateral or unilateral, and what are your indications for not doing a bilateral?
No, I would prefer this patient bilateral in the same sitting because she is heavy and she has severe deformity. If you do one side at a time, the other side is very bad.
She won't be able to
so we will not be able to mobilize her. That is one. Regarding the surgical, surprisingly sometimes these patients, the surgical release, careful surgical release can be such that you may not require a constrained implant.
Okay.
But you will definitely require an extension stem, preferably on both the sides, and constrained implant has to be ready in the operation theatre so that if you need to use it, you should have the TC3 kind of implant.
Just a question for the benefit of the audience. So what is your cutoff line for, cutoff age for bilateral? When would you say ki, this is the age, I will not do it? That's, do you have any age?
For me, all the patients can be done the bilateral.
So you age is no criteria.
Accepting the patients where the stress echo may have some issue. The anesthetist has the medical comorbidities are the restrictive factors.
So age per se is not a barrier.
It's not a barrier.
Does anybody keep that in mind?
Well, I think there is literature saying that if you're in your late 70s, there's an absolute contraindication because there's a much higher mortality. So I think age is an issue at the upper end.
What we try to do is, I keep 70 as a cutoff, but can we, so does Dr. Ashok, Rajesh?
Our cutoff is 75.
75. Rajesh?
My cutoff is 70 if no comorbidities and 65 if there are multiple serious comorbidities. And none of the patients with cardiac disease ever get a bilateral.
Dave, any thoughts?
So for me, it's not so much age, it's actually the physical condition of the patient, because it's very difficult to say someone's 71, that's too old, and someone's 70, that's okay. So really that's a consultation with the anaesthetologist and looking at their ASA grades, because there's some very fit people about who are elderly.
Yeah, so I think any associated comorbidities more than 2, especially if you have a cardiac issue, then I think it's better to get a stress thallium done. I think that's a good test to do, and it's always better to be safe. But at the same time, these are the cases, if you don't do them at the same stage, then probably they won't benefit. But you've got to really consider the risks which you are putting your patient to in case of the patient having comorbidities.
And these obese patients can sometimes have obstructive sleep apnea. So you have to be very careful about that, and that makes an additional risk factor.
Yeah. So
would you use a tourniquet?
How many of you in the panel, please raise up your hand, would you use a tourniquet?
When you're doing a bilateral obese patient, would you use a tourniquet?
So 1, 2,
only for cementing.
3, 4.
Okay.
So the others don't
I won't use.
The others don't use tourniquet at all?
Is it only for this case that you would use, or you use it for all cases? Would you use it for all cases, tourniquet?
Yeah. Just for cementing.
Only cementing.
Yeah.
Those of you who don't use tourniquet at all in their cases, even not for cementing. Yeah. So let me see here what the audience feels. How many of you use tourniquet for all your cases till cementing?
From beginning to end, only cementing, and never.
Yeah.
Stop using the tourniquet.
So Arun, you're in the minority. Well, so just to take on with this case, Rajesh, can you tell us the sequence of release and how will you reconstruct the defect? What is in your mind very quickly, and we'll just go on to what we did.
In all these cases where there's a fracture or there's a deformity, I need to put in a stem, I'll go for intra-articular tibial resection. Before that, the release on the medial side is very tricky because you have the risk of injuring the MCL. So go with the usual medial parapatellar approach. Be very careful when releasing the medial collateral ligament there. And again, it may be adherent patella. I'll not be in a hurry to dislocate or evert the patella. I'll just keep it in place, sublux it laterally, and gently sublux the tibia forward and put an intramedullary rod, take an intramedullary cut, and that will help me decide about the femoral rotation also, because this could be having a very large hypertrophy of the medial condyle, like Dr. Ashok Rajgopal said, and we see that in these cases you tend to internally rotate. Right. So I think the posterior medial release and the posterior lateral corner also, because the popliteus may need some pike rusting. That's what I'll...
Right. Okay, so just for paucity of time, again, we did a one-stage bilateral. And this was the side where we did this bone grafting directly by putting the graft which was taken from the upper end of the tibia. The opposite side, we did a graft by the KHS technique. My father has described this rectangular slot where you put a graft inside and then reconstruct it with screws. So this side we did the press fit technique. And these are the post-op x-rays. So right side we had to put the extension rod to left side, for bypassing the stress fracture, and also because of the severe varus deformity on the right side, an extension rod, and here the defect was cleared with the graft and the screws. So this is the post-op x-ray. X-ray at 1 year, you see the stress fracture healing up pretty well, and this was her gait.
Parag, if we see the AP view again, we see that slightly more opening on the medial side.
Yeah.
So did you have the slight, some amount of medial collateral ligament injury?
No, not really.
Yeah.
You know. So she was fine, and she's now 8 years down, and she's doing pretty well.
Rajiv, you can forget about attending the next APAS.
The medial space
No
is more.
worries, no
Yeah.
worries.
Did we see her walk? We only saw 2 steps.
See the gate.
So her varus was completely corrected, completely pain-free, unaided gait.
She has a bad deformity in the feet.
Yeah, we didn't do. Yeah, so if you see from what we started with and what we ended, I think she's pretty happy. We'll go to the next case.
So you were talking about feet. A lot of our patients you'll find have significant flat feet. And we've written that up in the CORR, that when you have significant flat feet, even if you get your HKA perfect, actually the weight bearing axis goes lateral to the center of your knee joint. And therefore you may have some degree of opening up of the medial collateral or stretching of the medial collateral. So therefore you should undercorrect these patients.
Well, so leave it in the natural alignment, as it were.
Slightly.
I just wanted you to say that. I just wanted
kinematic alignment,
Yeah, no,
David.
Good case.
I would have done this
a
with
little bit of
kinematic
variance.
alignment straight away. I would, definitely. I just wanted to ask, we were just talking about the way she was walking. There's almost a neuropathic gait about that, isn't there? And you just wonder how she got as bad as she was if she didn't have pain in the knee. And so I'm just asking, is there a degree of Charcot
No,
nature
she didn't
about
have.
it? No, she
was
could feel.
not diabetic. She did not have an element of
Parag,
Charcot's.
it's a very good result.
Yeah.
The one reason that these patients take a lot of time to recover is that they have not been using their quadriceps for a long time. So they take a lot of time to recover from their quadriceps weakness.
Rajiv, we'll reconsider you for next year now with that comment. Now this is the next one, guys. Adult male with this old injury. No infection. He's about 70 years of age, 6 feet tall.
Yeah, so
Any thoughts? So the question really is intra-articular versus extra-articular correction and type of implant. 2 questions. Yeah, Ridian, you're all set.
So this is a significant extra-articular, and whereas I'm certain you could correct everything with intra-articular osteotomy, I think you're better served by getting the limb aligned so you have a more straightforward joint to do. And I personally would do this as a one-stage extra-articular osteotomy with a stem or sleeve extension to bypass it.
Anybody else has any different thoughts? Only all intra-articular correction, and would anybody go for all intra-articular? Yeah.
With navigation.
With navigation, all intra-articular.
How do you decide that preoperatively, guys? Is there any way? Or can I just, in the interest of time, just draw these lines and show
Wang
you?
has described this very well. This is an article which I think everybody should read. This line, as long as you maintain the integrity of the collateral ligaments, and on the tibial side, if it transects within the 2 condyles, those are situations where one stage can be managed.
So now if you did a resection like this, there's a very high chance that you will be in a difficult spot to try and get your extension gap rectangular, because you're taking off so little on the femur and so much on the medial side, and so much on the lateral side and so little on the medial side of the distal femur. So you're going to have a tremendously angular extension gap. To try and make that into a parallel balanced gap is pretty difficult. It's easier if you did an extra-articular correction here. That's what my thoughts are in this case.
You would need a pretty generous medial release on this side, and possibly the need for a constraint.
Arun, this patient has a shortening on the left side.
Significant shortening.
Which will also improve if there is a osteotomy correction.
So would that be an open wedge or a closed wedge? If it were an open wedge, you'll get back the length, but if it were closed wedge, you wouldn't.
Yeah, open wedge.
So it would be a multiplanar correction.
You can use the graft that you take.
Mohammed, any role for PSI?
Yeah, I think I will use the PSI, and possibly I can do this intra-articular correction. I did some cases with a deformity more than 20 degrees.
So are there any guidelines that you would decide whether PSI is suitable or not? So is there anything for us that will prevent you from using a PSI?
Okay, I mean, if I understand your question right,
No,
I mean,
because if the deformity is too severe, suppose, let's say.
I routinely use PSI, but for anyone who's not using PSI, the guidelines is the degree of the deformity.
Yeah.
And you have to look at it from coronal, sagittal, and rotational. So sagittal is more forgiving because it's in the plane of motion of the knee. So I had the cases with like 30 plus deformity on the sagittal plane, and I corrected this partially. And you know, the patient is 8 years now down the line. For coronal, I mean, your limitation is the attachment for the collateral ligament. So you are between 2 to 3 centimeter on distal and posterior. And if there's something around the 20, you still can do it with intra-articular correction.
So Arun, what did you do?
Okay, let's move on. So here we did an extra-articular correction. We didn't have sleeves and stem at that point. A sleeve, so we've used a stem and a derotation plate. We'd warned him that he's not going to regain his length because that's what he'd lost at the time of the original fracture. So he is somewhat shorter on that side. He's okay with that. So this is what we did, and it's now about 5 years post-op, and he's still doing quite well. In fact, he brought his wife for surgery, and we did a uni for her. Okay, a slight variation on a theme. So going back to this one, the closer an extra-articular deformity is to the knee joint, the greater its impact on the alignment. So if it's very close, around 20 degrees, you might get away with intra-articular, but you should be prepared in case your medial release is going to be so huge, then it might be better off doing an extra-articular. If you're not happy doing it in one go, you can do the osteotomy, get it okay, and then do a total knee in a second stage. That's also fine. So this is a variation on the same theme. This is more of an angular deformity. Guys, this is a very unusual condition for India. That's the clue I'm giving you. What's the diagnosis? Yeah, it's Paget's. So it's very rare in India, but this was actually a lady, a physician's mother, and it was Paget's. So look at the femoral bowing. Incredible, isn't it? So any thoughts about correcting this now and the type of implant? Intra-articular, extra-articular, and implant. PS, constrained, or CR?
Yes, Michael, you want to go for this?
I think you can do I do a navigated PS knee, noting that the femoral deformity is biplanar, and I think navigation would be essential here because of that. I think you can't use certainly an intramedullary femoral rod. I have no experience with PSI, but I think you could use a posterior stabilized cemented implant with navigation.
And all intra-articular correction.
Correct.
Yeah. Any difference, anyone? Any other thoughts?
What about the right side?
There is a lot of procurvatum of the femur, and that's why probably when you are implanting the femur, some amount of extension may be useful.
No, I think the right side we'd probably do a uni, isn't it, Chris?
We are talking about the left side.
I don't know if you do a uni, but we do a uni, Chris.
We just asked the panels how many would do a uni.
Yeah, why don't we take a show of hands?
On the right side.
Right side.
Uni.
So how does it work? Would you do a uni on one side, a total knee on the other side? Have you done that, Chris? And does it matter to the patient? Does he say, you know, this is my better knee, that's my not so good knee? Do you have that?
Yeah, I mean, we've certainly got that. I mean, it really rather depends. Normally the scenario is they've had one side first. So if they've had one uni, so say the right side was a uni, you could actually discuss the left side as a uni in this case, because it's elderly patient, I think. Is that not right?
Yeah, about 7.
Yeah. So I would certainly have that discussion on the left side. If they've had a total knee on one side and it's really good, then you're in trouble trying to convince them to have a
So which
partial.
side would you do first if you're going for a staged? Chris?
This is one of the rare cases I do a bilateral uni. We don't often do bilateral unis. I just think you need to discuss it. I'm not saying that for the exam purposes, everybody out there, I should say, oh, we must do a uni on the left-hand side. But what I'm saying is that in elderly patients who have significant deformity, if you try and correct this, with a navigated total knee, there will still be some degree of malalignment here. You just can't get rid of that. So I'm saying that, in elderly patients, sometimes a small operation is really good for them.
And that's an excellent question that we should avoid as far as possible to have two different implants on the two sides. We have done that, but there is always an issue. The patient may think that this one works better because this has got X implant and this works better because that's Y implant.
Okay. So this is what we did, a standard PS implant with navigation, and we were able to correct the deformity, Chris, without leaving any residual deformity behind.
Well done.
And the scanogram on the right is a 1-year follow-up. So I think when you correct it, the femur does undergo some degree of remodeling. You can see the amount of bowing that was there is somewhat less.
Where's the lateral though? The full leg lateral?
I have that, but it's not here. The anterior bowing stays, but I think the frontal plane bowing tends to improve, I think.
And one more thing for those who don't use navigation, I think you slightly need to lateralize your entry point, otherwise you can cause perforation. So that's one of the tips. For those who use navigation, then it becomes easier.
That's our reference. That's one of our papers that we had published many years ago with a very large series of these extra-articular deformities. Okay, so guys, this is the next one now. This is actually a bilateral problem, but I want to focus on the left side. So let me tell you the problem that we had. There is significant bowing on the femur, and there isn't much by way of osteophytes and so on the medial side. So it's extremely rigid deformity, which is very difficult to correct. Even the soft tissue release, unless you did a massive release, it was just not correcting. I think I have some images here. Okay, so these would be the resection lines if we aimed for a reasonable mechanical alignment of the tibia as well as on the femur. So this was our initial alignment, 21 degrees, and after our release, it was still in about 6 degrees of varus. After doing whatever we could, reduction osteotomy, posterior medial release, and so on. So at that point, what we did here was
so maybe
we
can just ask.
Yeah. So guys, would you ever consider this, just for your?
Yeah. So what are the other ways, Rajgopal sir, for correcting this residual varus? How often would you go and release the superficial MCL, or what's your bailout once you're left with this residual varus, fixed varus, it's not correcting anymore? You've done all possible releases.
To be honest, I haven't seen that situation. I think you should be able to correct the varus if it is purely a soft tissue contracture. I tend to shy away from osteotomies and pike twisting the medial collateral ligament. That's a no-no for me.
So how often do you need to release the superficial MCL? That brings us to a little bit of that discussion, because now it has been said that try and release that as the last, if at all you have to.
Absolutely. So that's pretty much my last release, in particular in patients who have concomitant flexion contractures. But oftentimes you'll see these with varus and flexion contractures. So you do all your soft tissue releases, and if at the end of it, you still have a certain amount of residual flexion contracture, 5-10 degrees, releasing subperiosteally, going a long way down the shaft of the tibia, will release the superficial collateral. You don't have to worry about the integrity because it's subperiosteal, you're taking it down with the sleeve, and it allows that extension, that last 5 degrees of extension to come through.
Yeah, but I think medial condylar osteotomy is a good...
I don't think there are too many takers for it, Parag. Yeah.
Yeah, I have experience with such a case. Is that I mean, if you don't have PSI, it's better to use a deformity correction analysis by Durer-Perley, and if you can look at the angles, you know, the medial proximal tibial angle and lateral distal femoral angle. And the message is actually, he said it yesterday, I don't know when he said that, minimal bone resection, because if you resect more bone from the medial side, from the lateral side, then you get into trouble. So it's actually, one way to avoid this is to resect as minimal as possible from the lateral, and you will end up with less gap on the lateral side, okay? I also had one case like this, and post-operatively, we had to reconstruct the lateral. I know it doesn't work. It was like a hamstring and going through the fibula. It doesn't work, and it didn't work, but this was the only salvage procedure.
So anyway, this is required very rarely in only those recalcitrant deformities which are really very, very rigid, and you've done everything, and the next step is to literally take the entire superficial MCL off, peel it off completely off the tibia, and that's something I don't like to do. So instead of doing that, because the problem really is, if you think of it, the head of the femur is there and your two epicondyles should be perpendicular, more or less. But it's like this because it's in varus, because of the bowing. So all you need to do is to bring the epicondyle down, and you don't need to do any release. So that's exactly what we've done. So you bring it down by 6 millimeters, and you convert your 6-degree angular deformity into a straight parallel extension gap, and then fix it with 2 or 3 screws. This is navigated, as you can see, and that gives you a very good final alignment. So here you can see the medial epicondyle has been brought down, so you don't need to do anything to the entire femur. You just need to bring the epicondyle down, fix it with screws, and you get your alignment. You can use a PS knee. You can see the vertical surface here on the medial tibial side where we've done a reduction osteotomy. So we've gone through all the steps. It's a PS knee, the joint line is restored, and we've done no soft tissue release. The superficial MCL is totally intact.
Yeah, so I think this paper is good, but what I want to say is sometimes it's good to plan what Arun has just said, because there have been occasions when actually you're trying to put in the poly and then you inadvertently create a medial epicondylar fracture. And that time what happens is the difference is the piece is too small. Here you saw Arun could get in 3 screws, you can barely get in 1 screw, and I've had that complication in my own hands. You know, at that point of time, when you're reaching that stage, you know, it becomes difficult. But these, even if it does fracture, they do heal up well, as long as you can actually fix them. So I think this is a good option, and one should have the know-how how to do it and fix it back.
It's just as a last resort, really. You don't really need to do it very often.
Arun, could you have also tightened up the lateral, doing the lateral epicondylar osteotomy and tighten up the lateral collateral ligament instead of distalizing?
This was actually very rigid. There wasn't a problem on the lateral side. It wasn't that the lateral had stretched out. It was just the medial side was very, very stiff. That was the reason. But we've done that occasionally. But I'm not sure it really works. Okay, guys, let's switch from varus to valgus now. Let's move on to this. Have you got a long leg X-ray? Yeah. These are the long films for those who need it. You can't see, unfortunately, on the right hip, she has a badly done monopolar, like an Austin Moore hemiarthroplasty on the right hip, just to add to her woes. And you can see the severity of flat feet, which adds to the valgus deformity and is often part of it. So these are the X-rays.
Yes, so
Chris, let's stay. Lateral uni?
Definitely not. Definitely not. I mean, this is a type 2 valgus deformity because the medial side is opening up, so the MCL is a bit incompetent, you might imagine that. Patellofemoral joint arthritis. The initial issues are whether to go in lateral parapatellar or medial. I've tried both. Lateral has many advantages theoretically. I mean, you do your release as part of the incision. The problem is the medial side and getting to see the medial side, and it's quite often difficult to actually position your tibial component rotationally and also coronally. So I've gone back to using the medial side, even in the severe valgus. You then got the issue of releases. You'll probably have to release an awful lot on that lateral side. Popliteus will probably have to go. I would use a PS on the femur. Normally I would use around about 6 degrees, but I would dial it down to 4 or 5, probably a 4, depending. I don't use navigation, perhaps I should. And I know that you're going to tell me what I should be using it on the navigational side. So that PS femur, and then on the tibia is relatively straightforward. Patella, you'd have to resurface, or at least I would resurface that, although I gather there's a study from Northern Ireland which suggests you don't have to. So I would hope to be getting away with a PS, but I would have a bit more constraint if necessary.
David, anything else?
No, I think that's very reasonable, actually. I can't see that I would do anything different. I also think that the problem with the lateral approach is that you're not doing it very often, and you're doing it on some of the most difficult knees that come along. So you're really loading up stuff against you. So I think if you want to use a lateral approach, it's a bit like Chris's point with the Oxford. You've got to be doing it all the time, not on just the most difficult knees. And I think this kneecap will be very difficult, certainly on the left, to dislocate because it's almost ankylosed. So I also use a medial approach.
Okay, just to show you the value of full-length X-ray, you might not appreciate it in this, but once you start drawing your cuts, you can see that there's an extra-articular valgus deformity on the tibia as well. So if you just stuck to these X-rays, you might miss that completely, and you'll see it in the post-op X-rays, the value of that. So,
yeah, so before Arun shows what he did, so for a severe valgus deformity, you know, something more than this, how many of you use a lateral parapatellar arthrotomy than your medial one? So can I have, yeah, so.
Anyone uses a lateral approach? No.
So everybody for severe deformities also you would use it? I think that's what, initially I have used that, but I think over a period of time, once you get the experience, you can deal with the most severe valgus deformities. There was some discussion in the morning about using a lateral parapatellar arthrotomy, but I think one can get away without doing a lateral parapatellar arthrotomy.
The only time I do it is if the patella was already completely dislocated, and I would then use a lateral approach, because I know for sure I'm going to have to do a lateral release, so I might as well do a lateral approach and minimize the devascularization of the patella. So this is what we did. And this is why I'm pointing out, you know, how the tibia looks like it's in varus, the tibial component, because there's a significant amount of valgus bowing off the tibia. So this would look like it's in varus, but it isn't. So here we had to do the left, as everyone said, was the worst deformity. So here we've done a lateral sliding osteotomy. Again, because it's stable, she's a younger person, we didn't want to use a TC3. But you can keep that as a standby option, perhaps in the older patients. That's her final alignment and the long leg X-rays. We've also done a revision of her hip. So we've got a long stem prosthesis out there.
So Arun, I know you always resurface the patella, but how many of you in the panel never resurface? Can I have a show of hands? Never resurface the patella. Mohammed, Rajiv, Rajgopal, 3 of you. How many of you are selective resurfaces? So Ridian, when would you select to do a patellar resurfacing? In which cases would you definitely do a patellar resurfacing?
So for me, it's all about patella height. And if you've got severe erosion, often these very valgus knees, it's been overriding the lateral condyle for many years. And it's a very thin patella. And if you want to restore patella height, then the only solution you have is resurfacing. But, you know, that would be a rarity. In the majority of my cases, I don't resurface and I don't worry about it. But these cases, I think about it.
You think about it. So how many in the audience, how many of you resurface the patella routinely? Very few. How many of you are selective resurfaces? And how many of you never resurface at all? Yeah. So Dr. Rajgopal and Rajesh have a lot of followers, and Rajiv. Okay. So I think that's a question which we'll never be able to answer. You know, the debate would continue to go. Let's go to the next case.
So we continue with the valgus deformity, and now this one is slightly different from the earlier one in that it's opening up tremendously on the medial side, medial collateral. It's a massive deformity, but it looks worse than it is because there's an element of hyperextension. You can't see it here, unfortunately, but it's in valgus and hyperextends about 20 or 30 degrees. The other side was done elsewhere some time back, and you can see it's opening up laterally and not that stable. And she has some lymphedema or some sort of elephantiasis of the leg, and is hyperextending. Let's go back to this.
Yes, so
any thoughts, guys?
Rajiv, what would you do?
See, here you have the medial collateral ligament is definitely jeopardized. One has to be very careful. This looks like a type 2 valgus deformity. Release laterally. One has to have the constraint implant available. Maybe a hinge as well. Here the lateral epicondylar osteotomy should be a big help in my hands. And I'll definitely use the extension stems on both the sides, femur as well as tibia.
Michael?
I think I'd probably use a hinge on this lady. I've got no experience in epicondylar osteotomy, and she wouldn't be my first. I think the medial ligament's going to be incompetent. You've got recavatum, and I think she needs at least a semi-constrained implant, but in my hands it would be a constrained rotating hinge.
Yeah, I would agree with that. And I think with modern rotating hinges, there's actually less constraint than in a varus valgus constrained LCCK type implant. So I agree with Michael, I would definitely go for hinge here.
Okay, so in fact this is her immediate post-op image. This is a 1-year follow-up. We have a 4-year follow-up as well. So a sliding osteotomy, put a longer stem only on the tibia, but it was extremely stable medially. And the osteotomy has healed, a lateral sliding osteotomy. I was able to balance out the ligaments, the joint line looks okay, and she was quite happy.
So, Arun,
this is her 4-year follow-up now. Everything's still the same. She's luckily lost a little bit of weight, and the osteotomy still is doing quite well. Yeah, sorry.
So, Arun, one question to you here: that if, in case you would have found that the MCL was incompetent and not functioning at all, is there a way to do something like a LCCK or TC3 type of process, or do you have to go to a hinge?
I think if it's a low demand patient, I would put in a TC3 type of implant, and if it was a younger patient, a heavy patient, I'd put in a hinge.
Anybody MCL incompetent knee, what would you do?
If it is one ligament, I mean, you still can use CCK, but the problem is that if you have the posterior capsule here, especially that she has got recurvatum, so if the posterior capsule is weak, then it's better to use a hinge.
Let me clarify the purpose of a TC3 or a CCK. Having a bigger post, a bigger piece of poly is no substitute for ligament stability and integrity. So if your ligament is really gone, the MCL, it's really a hinge. TC3 is really it's not really a great option unless it's a low demand, very elderly patient, short lifespan. You might get away with it for a few years, but if you did that in a 45, 50-year-old, I think it's not going to work, because that the post is either going to fracture or wear out.
Yeah. So whenever you're doing a severe valgus knee where you think the medial collateral is incompetent, always have a hinge as a standby, because that's a good bailout.
Arun, you have been very lucky, because these lymphedema patients have a very high incidence of periprosthetic joint infections, and we always discussed at length, and the risk is in some series almost 50%.
You're absolutely right. You have to point that out to the patients, that the wound can keep dripping for a long time, and you've got to be very careful with your dissection, meticulous closure. You might want to hold on before you mobilize them. So luckily we've done an osteotomy, so for 2 weeks they're in a brace, we don't mobilize them, let everything heal. I think that's a very good point, Rajesh.
So quick last case, we have time.
So that's, if you want to refer to recurvatum deformity correction, that's in the Journal of Bone and Joint Surgery. And this is the last case. This is a young lady actually. You can't imagine how lucky we are she's barely 30 years of age, bilateral rheumatoid with these malunions on the tibia on one side and on the femur of the same side. So you've got a malunited femur on the right, that's a malunited tibia on the left, and bilateral rheumatoid with 20-degree flexion contractures. That's the overall picture. So the left side is pretty straightforward. It's almost like a rheumatoid knee. So you do a total knee in that, correct the FFD. The right side, guys, has a dual deformity.
Yes, David, you want to say something? How would you tackle this case?
Probably do the left one first, actually.
Sorry?
I'll probably do the left one first, and then I'll pass it on to someone else. Yeah, I've done the left one.
And then proceed on long leave and go lecturing all over the world.
Yeah, that's right, and then I'll go. Do we get to see the right one? So I think the left one's relatively straightforward, so we can do that. I would do that with a total knee. I think the right one, is there a picture of the right one that's a bit closer? Because we've got two deformities there, and we've got the insufficiency fracture there. So I think that's too far away to correct with interarticular correction. I think I'd have to do an osteotomy over a stem and a sleeve. And I think I can't see if we show the femur again. So maybe the femur doesn't look too bad. I'm not sure. So I'm not sure what to do with the femur because it's quite a long way away, but it's quite minor. I'm not sure. Would you change that, Redden? Would you osteotomize that?
So, I mean, I'd want a CT scan to really know what my angles are above and below. And here, I would do this as a staged procedure. So, a young patient, I'd correct as much of the deformities I could below and possibly above. But I'd want to know how big that femoral deformity is. The tibia, definitely, I'd do beforehand. The femur depends on the angles when you CT scan it. But if I had to, retrograde nailing the femur, antegrade nailing the tibia, correct everything, second stage replacement as and when.
So just for my information, so what would be the advantages of doing it as two stages?
So she's a young patient, and if you do have to if it's purely the tibia, I do it as a one stage. If you're talking about correcting a deformity above and below, I would do a two-stage procedure, get the correction I wanted, because it's a big, significant insult on anybody. She's 30, she should have come through it well. But I think you need to just get a zone of quiescence where the bones have healed, the alignment is as good as you're going to get, and then you do the implant.
Okay, so I
think... Michael has something to say.
Last
Quick,
comment.
Michael.
I think, firstly, she's rheumatoid, so osteotomies are going to be slow to heal and so on. The real critical factor is whether she's got a fractured tibia. If the tibia is just deformed, a malunion, I would just do a PS knee on this because what she's done is self-correct. She's got a varus femur, valgus tibia. She's got a slightly valgus knee.
So you're saying leave it in valgus?
She's almost, I'd do a correction, but what we've got to correct her mechanical axis is only looking about 5 degrees of valgus. So
I think before Arun shows what he did, this is the importance of long leg x-rays, because if you just take short films, there is a big possibility that you might miss these fractures, miss these deformities, and then, intra-op you'll have problems. So Arun, what did you do?
So I thought, and we did a bilateral. So as David said, we did the left first. That was easy. On the right side, we had to do an osteotomy. We ignored the femoral one because we did some degree of intra-articular correction for that, and an extra-articular correction on the tibia. So that's what we've got away with. And that's the patient, young girl, corrected the FFD, and she's quite happy. Okay, so guys, sorry we've run out of time, but thank you very much for being a very wonderful panel. A round of applause for them for suffering through this. Thank you so much, guys.
So thank you. I think the message here is that end of the day, there are various ways to